Welcome everyone to today's webinar. This webinar is being hosted by NASTAD, and today we're going to be talking about prioritizing leadership development of community. Today's webinar is the second webinar in a series of four that will be highlighting achievements in EHE. So today we'll have a welcome and overview, and then we'll have presentations from the South Carolina Department of Health and Environmental Control and the Maricopa County Public Health Department. And we'll also have some time for Q&A. So we encourage you to use the chat function or the Q&A function to ask your questions at any time. We will be sharing the slides and the recording from today's webinar with all registered participants, as well as on NASTAD's website. So today's webinar is a part of NASTAD's National Technical Assistance through PS 19-1906, which is a CDC cooperative agreement, where NASTAD is able to provide technical assistance and support to state and local health departments that are funded through PS 20-2010, and also through HRSA funding for HRSA 20078. And so just to remind folks that NASTAD remains available to provide TA to EHE jurisdictions that are funded through CDC and HRSA. And we also would like to just let you know that the next webinar following this one will be next Tuesday on the 14th, focusing on promising procurement practices for HIV prevention and care programs, and that will be at 2 p.m. Eastern Time. So today we're hopefully getting to get you to think about why it's important to invest in, engage with, and include community in HIV workforce development and leadership. These are just some reasons to consider when you're creating or building workforce and leadership development initiatives. We're just briefly touching on them today, just to get you to kind of think about them, but these are topics that, we could do a webinar each on. So we're not going into a lot of depth today, but just wanted to highlight some key points. So the first reason is for parity, representation, and inclusion. So does the workforce represent the communities being served? Are you going to be able to achieve prevention and care goals if the community does not trust in your organization to be effective and to address the true needs of the community? So it's really important to have representation and inclusion of community members across programs and services, as well as from the top to bottom. So thinking about those who are working in leadership and decision-making roles. And then also thinking about, are we leaving anyone out? Which members of the community are not currently involved in decisions or providing ideas in terms of HIV prevention and care and what should be done in the community? And what are the barriers that are preventing people from being included? Are we also valuing lived experience the same way that we value other experiences or education? And how is that value being shown or counted? And then capacity building. How are we building up the community members to do the work themselves? Community members often know more about the needs of the community. So how is their input being utilized and incorporated? And how are they being included in decision-making and leadership and programming? And we also want to think about the sustainability of our HIV programs. We know that the public health workforce has been impacted in all areas, especially post-COVID. So what are we doing? What steps are being taken to address worker shortages and people leaving the workforce? How do we provide tools and knowledge to those who are new to this work? And then finally, thinking about the progression of our HIV prevention and care efforts and programs, is there true collaboration and involvement of community members in these efforts? So you're going to be hearing today from two EHE health departments who are going to talk about two of their initiatives. And these are just examples of some things that can be done, but not examples of everything that can be done. So we encourage you to consider these initiatives and implementation efforts, but also think about what efforts and what ideas would work well in your community and in your jurisdiction. So I'm going to hand it off now to our colleagues from South Carolina who are going to be talking about their community health worker program. So I will pass it to them to introduce themselves and share with us what they are doing in South Carolina.
Thank you, Krupa. I'm Tony Price. I'm the Prevention Program Manager for the HIV and Viral Hepatitis Prevention Programs at the South Carolina Department of Health and Environmental Control. I will ask William and Susan to introduce themselves at this time.
Hi, Krupa. My name is William Tanyi. I'm the EHE Prevention Senior Consultant, and I will be co-presenting with Tony and Susan.
And good afternoon, everybody. I'm Susan Collier. I'm the Community Engagement Director for the Midlands region with DHEC here in South Carolina.
And I want to start off thanking Krupa and NASTAD for giving South Carolina this opportunity to present on our EHE community health worker activities. I also want to just mention a practical note to William. I've noticed that I've been dropping low Wi-Fi internet connection in the past 15 minutes here. So if I drop off altogether, William, I'll ask you to take the baton and please continue without me. But with that said, if we can move to the next slide, please. We wanted to take this time today to provide you an overview of the South Carolina Community Health Worker Program under the Ending the HIV Epidemic initiative. We're going to discuss some of how the program developed, how it fits into our South Carolina EHE plan, give you some real-world activities that have occurred from the program, and highlight some of the successes and challenges and best practices, and wrap up with a few brief comments about how the program will move forward later this summer and into the latter part of this year. Okay, next slide. So I'll just mention that in our original EHE application, which most folks will recall that we were writing for EHE implementation at the same time our EHE state plan back in 2020, we wanted to include a PrEP champion was the initial idea. We wanted someone who would be based in each of our 4 public health regions, health department based, and someone who would have the skills of a DIS, but would not be performing the duties of a DIS, but someone who would be close to folks who are from vulnerable populations at risk for HIV. Between 2020, when that plan was written and our original grant application was submitted, and finally into early 2022, the position evolved from the idea of the DIS-like position to someone who we thought would be social worker based in clinics because they have direct contact with STD clients coming through who don't have HIV but are at risk. And then it evolved back to the idea of perhaps a DIS. And finally, we evolved it into the idea of the community health worker model. We felt like it was most appropriate to address the gaps in services and to achieve our EHE goals. We still had as a primary point, we wanted someone who would be able to talk to populations vulnerable for HIV, but who did not have HIV, they could explain PrEP and its benefits. But we also saw that they could perhaps serve a role across all 4 EHE pillars. And you'll see in just a moment, the sample position description we drew up addressed that. So we really looked at where there were gaps, health department-based activities, community-based organization activities, and we felt the community health worker model was best to do that. And we engaged our regional and local health department management, along with nursing, social work, DIS, and health education staff to come to that final conclusion. And just to note, this program is 100% CDC EHE funded. Next slide, please. Okay, so to get an idea of how we detailed what we were looking for at the state level and what we asked our regions to be looking for when they prepared the posting of the positions, we wanted to hopefully kind of jumpstart things, as things can often take a long time to move through the interview and hiring process for government positions. We provided the following as key job duties across the 4 pillars. One was being under the diagnose pillar to assist with reducing barriers to HIV testing for vulnerable populations and to have the community health worker to identify potential sites for the mobile testing services that we were funding through EHE prevention grant money from our community-based partners. Secondly, under the prevent pillar, to assist with reducing barriers to accessing PrEP, and in particular, to be able to conduct highly targeted outreach and promotion of PrEP services and promote referrals, again, to our community-based providers who were being funded to offer comprehensive PrEP activities. Next slide, please. Thirdly, under the treat pillar, we wanted to make sure that the community health workers were well-versed in knowing their counterparts in the Data to Care program based in each of the 4 public health regions as well, so that community health workers who happened upon someone diagnosed with HIV but not in care, that the community health worker would be able to link up with their regional Data to Care staff and at the regional level or at the state level to assure for efficient return to care for those folks out of care. And finally, we even wrote in the respond pillar to say that to assist as needed and when appropriate to assist with HIV cluster response activities in conjunction with the regional DIS management, along with any input from the central office. I will add that in terms of trying to look at those folks, we didn't use the term at that time with lived experience, but we were somewhat aligned with that concept that we indicated preferred qualifications for all of these positions was a knowledge of and experience in working with LGBTQ communities, as well as with persons with substance use disorders. And we also indicated a preference for bilingual applicants. Next slide, please. And now William will take over and talk about the actual rollout of the program.
Thank you, Tony. So having developed the position description and key job duties, the next step was to proceed with staff recruitment. And this step was easy to complete because there was already an existing community health worker program model that was supported by our Midlands Public Health Region. And Susan will talk more on this because she supervises that program and she's a community engagement director for Midlands, so she will talk more on that. So with that program already existing, we use that as a pilot, and there were already staff supporting that program. So we proceeded with training and orientation programs for the staff. Again, we were intentional with the selection of staff. It should be bilingual in nature, Spanish and English speaking, experience working with the LGBT population and people with lived experience. And so for the orientation programs, we discussed the epidemiology of HIV because our community health workers, they support other activities, not just HIV related. So we had to bring them closer to the HIV world by really giving them a little bit of education of the epidemiology of HIV, how HIV is transmitted, the prevention and treatment modalities. So meetings were set up with our programs leads that cover the various pillars, like Tony mentioned. The duties span across the various pillars. So we invited our various program leads to also hold training sessions with our community health workers so that they would be versed with activities that are covered under each of the pillars, the diagnose, treat, prevent, and respond pillars. So at the end of the meetings, there were materials that were shared for self-paced learning via email so that our community health workers could study on their own and get more knowledge on what we had in mind for to achieve for the program. Next slide, please. So having completed this pilot phase, the next phase was the expansion phase, because like I said, the pilot phase was just concentrated around the Midlands. So we had to include the 3 other public health regions. Just for information, our state is divided into 4 public health regions: the Midlands, the Upstate, the Low Country, the PD regions. So we all had at this point to make sure that we expanded the program to include the 3 other regions. So they were also brought on board, and they were trained. And then the next phase was our stakeholders. It will be difficult for our community health workers to work without really having a referral structure. And most of those areas are being supported by our funded CBOs. So we had to make sure that we link up our community health worker with our CBOs, so that in the event of a referral, for example, someone who would test positive and needs to be linked to care rapidly, they should have handy information on how that process works and who to call. So we had to bring in our funded CBOs, HIV prevention and treatment providers, and also substance use and mental health counselors who support our activities. So once that was done, the next phase was meetings. We made sure that we included our community health worker in our meetings. We have quarterly meetings that bring together our DHEC regions and central office staff. So that also helped as part of staff development to really support and help our community health workers in this new role that they are to play with respect to our EHE activities. So depending on where they work, they have various roles and the pillars they support as well. For example, they support roles as peer navigators, linkage to care coordinators, patient navigators, health system navigators or counselors, and then also as promotoras. Promotoras, that was a Spanish version for community health workers. So they would also take this role in the community, just like Krupa said, the ability for them to have that trust. They are the boots on ground. So we really made sure that they had a background that reflects the people they're gonna serve. So we have a very huge Spanish community here. So we made sure that we included the Spanish-speaking community health workers as well. So after we completed that, the next step was trainings. Which other trainings will benefit our community health workers? Just like we said, the activities they're going to deliver would be pillar oriented. So we'll make sure that each of they had trainings across the various pillars. For now, they have completed the training with the diagnosed pillar, and that is the HIV home testing training completed. So other trainings have been planned. So we see that with time, that also will be accomplished. Next slide, please. So Susan will come in now to discuss the real world activities of our community health workers. Susan, please.
Okay. Thank you, William, and thank you, Tony. And just before I get started, I'd like to say that the trainings and support that we received from central office were really integral in providing our community health workers, which are already on staff, those resources that they needed to better support their communities as they were working in those communities. And the Midlands region consists of 12 counties in South Carolina. We have 46 counties in total, but for the Midlands, it is 12 of them that are covered. So our community health worker model is a little bit different than some organizations do. We don't receive all of our referrals internally from the agency. Our CHWs really work to meet people where they are. They are truly our boots on the ground workforce. They use their knowledge of their counties and their communities to really reach out to those marginalized populations to provide them the services and resources and connections they may need. And it's really a high priority for them to really address the social determinants of health when they're working with their clients. The other thing that we've done with our community health workers is they have blended funding. And that allows them to not be restricted in their work. They're really able to address that whole client. So when they're able to do that, that gives them the flexibility to really meet people where they are, because they may not always be ready to address that particular topic that they may be funded on, but they can get to know that person. The The focus counties for the Midlands, we have 3 focus counties, and those 3 focus counties were chosen based on data, but they were also chosen based on our community health workers and their interest and their passion and their lived experiences, as Tony talked about, around the Ending the Epidemic initiative and the desire to really make some positive outcomes and turn that curve of those rising rates around HIV and STIs. And I think that a really great example of this is that one of our focus counties is Saluda County, and they have a very, very large Hispanic population. And we were very, very fortunate to already have a bilingual staff who was passionate about this topic to really move in and really help us work in Saluda County. Next slide. So our outreach is really focused on our high-risk populations, and I'd like to give an example. Because this is a success, but it's also a great example of how our community health workers really do accomplish their job. With their thorough knowledge of their local areas, because the vast majority of these folks that we have hired are residents in those communities, and they know, and they're an established individual in those communities. But this particular staff was really able to identify the motels where sex workers lived and worked. And an example is there was one woman who was living out of that motel where she worked as a sex worker, and she struggled with drug addiction. And over the course of many months, and I think it's important to note that our community health workers do not have a one and done relationship with folks. They really do establish a long-term relationship. But she was able to, our community health workers were able to assist her to get into rehab, connected her with some resources to finish her GED. And she assisted her in finding housing after she found a job, which also allowed her to regain some visitation rights with her children. And I think that this kind of a success, not only is it a tremendous success for this individual and of course for our community health worker, but it really further supports our community health worker in those communities, because word of mouth is really big. And it really shows them establishing this relationship. And of course, through this whole process, she was at high risk for HIV. And so of course she got all of the education and the resources to connect her to any of those things that she needed. The other thing is that they have really worked hard to partner with local organizations and businesses, and they've established condom routes, is what we call them, where they have condom jars that are placed in bars, barbershops, salons, pharmacies, shelters, and there really have been thousands of condoms that have been distributed. And then the other success that they have had is that they really collaborate closely with our CBOs to identify locations that would be some place to set up these testing events where the individuals will feel more comfortable. And some of these places have included shelters, store parking lots. There was a Native American health clinic. And then the CHWs work very closely with the CBOs to get information out about the community events to those that are most at risk, as well as more information about the CBO to keep increasing awareness about what the CBO does, what the services are, and to increase some participation in those events. Next slide. So the challenges, one of the challenges that they have had when you speak specifically about addressing HIV is that many of the folks that when they first come in contact, they have higher priority needs in their mind, such as housing, food insecurity, substance abuse. So they really do work to refer them and connect them with those resources to get the help that they need in those areas. Oftentimes, they also have very limited knowledge about safe sex, HIV, and STIs. And so our community health workers need to start at the beginning with some basic education and some simple concepts, and then kind of build from there. The other thing is stigma. They've had a lot of challenges because some clients don't really feel real comfortable discussing sex, HIV, STIs, and they're not real interested in getting testing done because in some cultures, there's a stigma around that. The other big challenge that they've had is getting the community to participate in the mobile HIV, STI testing units. What's happened is some folks don't want to be seen going into the units to get tested. Others have a general lack of interest or a real concern. And then others don't want to even bother to complete the paperwork. So our community health workers continue to work really hard to establish that basic knowledge that folks need to have to understand how important it is that they do get tested. And then there's some cultural barriers. Many of our Hispanic and Latinx communities don't have a real interest in learning about STIs and HIV. They don't see themselves at risk. And so they really want more information about family planning. So again, the CHWs establish relationships and work continually with folks to increase their knowledge and then access to those things that can prevent. And with that, Tony, I'm going to pass it back to you.
Okay, thank you, Susan. So just to wrap up here, we are excited about a collaboration that's occurring between the University of South Carolina, the Arnold School of Public Health, and our South Carolina AIDS Education and Training Center based at USC Prisma Health to develop an HIV-specific community health worker certification program. And our collaboration with that initiative is to get more DHEC staff, not necessarily just the limited number we have funded with EHE CDC funds, but to have more staff qualified to provide the HIV community health worker services in gap areas around South Carolina, but also beyond that, to coordinate and collaborate with federally qualified health centers and other community health centers around the state to offer the opportunity for their folks who are not necessarily, again, funded with our federal grants, but to have them go through the certification program, ultimately expanding the statewide workforce for community health worker activities throughout the predominantly rural South Carolina. So that's one exciting thing in our future. That's supposed to roll out late summer into the fall, and we're looking forward to how that will carry us forward into the next year of operations under EHE. That's all we have today. Thank you so much for your attention. And there's our contact information.
Thank you, Tony. Thank you, William. Thank you, Susan. I am going to now pass it off to our colleagues from Maricopa County.
Hi, everybody. I'm just gonna share this with y'all. All right. So, let's see. Just one moment. All right. Hi, everyone. My name is Jen Bailey, and I am the EHE Virtual Health Educator for Maricopa County, Ending the HIV Epidemic. Today, I'm thrilled to dive into our CHW training program with you. We call it CHAMP, which is short for Community Health across Maricopa and Pinal. And while our EHE projects are specific to Maricopa County, our Ryan White team also provides services in Pinal. All right. So our CHW training program is available to individuals ages 18 and up living with HIV in Arizona. To participate, they must have completed high school or obtained a GED or equivalent, and they'll need to have English reading and writing skills. Currently, the program is only offered in English, but we are actively working on prepping the content to get it ready for translation into Spanish. Our online program consists of 8 modules, and through that, we aim to prepare students in their professional development, which particularly benefits our staff at our partner organizations and our community providers. Additionally, it equips students with the enthusiasm and skills necessary to enter the field as new CHWs, contributing to our efforts here to end the HIV epidemic. So the content of the program covers the core competencies that are required for CHWs to obtain state voluntary license in Arizona. All right. So why did we implement this program and choose to focus on developing community health workers or CHWs? So here we're really focusing on the 4th pillar of the RESPOND strategy under ending the HIV epidemic, and we are HRSA funded, by the way. Our aim is to respond quickly to potential HIV outbreaks to get needed prevention and treatment services to people who need them. In order to do this, we've got to have people who are trained, ready, and already in roles that allow them to respond. So specifically, our program goals are to grow the HIV workforce by developing the skills of people with lived experience, connecting them to employment, and assisting graduates in obtaining their Arizona CHW voluntary license, and for future professional development opportunities. All right, so taking a step back and looking at a glance at what Arizona CHW looks like, or the CHW field, we are currently at an exciting time in Arizona due to recent legislative developments. The state has introduced several pathways for CHWs to obtain their license, and the application portal has recently opened online through the state. This new licensing avenue does not mandate licensure for CHWs, but it is designed to accommodate those already practicing in the field. So it recognizes their wealth of experience and contributions while also setting a standard of practice for the state. So you'll see here in Arizona, there are 4 pathways to becoming licensed. The first involves demonstrating 960 field hours, which can include paid work, volunteer work, or an internship. And so for those already practicing as CHWs in the field, this is often the preferred pathway. But the second pathway entails completing an accredited CHW training program, which reduces the required field hours to 480. And that is our program. So our program follows this pathway. So pathway 2 consists of completing an accredited training program from the accredited program by the Arizona Community Health Worker Association. So field hours are not required to be supplied by the training program itself, but we're implementing an internship to help with our students so they can access those field hours. All right, so this slide provides a brief history and timeline of the CHW training program here at Maricopa County, which would become the CHAMP CHW training program. Initially, the program was housed in a neighboring office within our department. Our office began collaboration with this office in 2020 to incorporate HIV modules and establish a new pathway for EHE students to become CHWs and serve in the field. In 2022, we relocated the program entirely in-house to provide additional support, which has resulted in increased enrollment. This is also when I was able to join the team as a health educator. I joined the team having previously assisted as an intern during the program's final phase in the old office. So with staff turnover, we were able to bring the program in-house, and it has really allowed us to focus our promotion efforts with our partners and our providers that we already work with so closely. Looking ahead, we are actively growing our collaborations between offices to ensure continued support and sustainability of the program. Accreditation is required every five years through ASCHOW, which is the Arizona Community Health Workers Association. And as we prepare for our reaccreditation this summer, we are exploring strategies to maintain our program relevance, update our content, and ensure continuous community input and engagement with the program. All right, so if we take a look at that first stop on the timeline, we focus on our curriculum and program construction. To accomplish this, we considered key stakeholders and staff responsible for program implementation. This included our CHW trainer, the topic content specialists, as well as input from the office's existing community health workers and partners, as well as community members. In developing the curriculum, we utilized various tools like Talent LMS, which is an online learning management system, Articulate and Storyline 360, PowerPoint, Zoom, WebEx, and Airtable, which served as the platform for applicant submissions and storage of applicant data. In our third box here, the curriculum itself covers core competencies, HIV modules, and information from the Ryan White program. Additionally, we determined that the required hours and duration for student completion. We also incorporated external vendors into the program, which is especially helpful for things like HIPAA compliance training, chronic disease modules, service delivery, and motivational interviewing. All right, so how do we know that we're developing the content appropriately? Zooming out to the national level, we look at national guidelines and industry insights to ensure quality. Resources like the Bureau of Labor Statistics and ONET Online inform our curriculum, keeping it relevant to current CHW trends and skills that have been surveyed as necessary by the nation's employers who staff CHWs. The C3 project also is a consensus project that establishes national consensus on guidance for what the CHW core competencies actually are. And then using that, zooming into the state level, we get more specific requirements for what our program actually has to look like. Of course, we have the CHW core competencies, but we're also looking at what the background of the trainers needs to be, determining what field hours are available, if any, and importantly, incorporating specific CHW involvement in the development of the curriculum itself. On our last level, you can see that's Maricopa and Pinal County there in the lower right-hand corner. Taking input from your more local level can look like including specific services in your curriculum that are local to the community you serve, looking at providers and what skills they post in their job description so that you know exactly what they need in their healthcare staff, and of course, incorporating feedback from actual students in the program. In our case, we are collecting feedback continuously throughout the training program through course evaluations and in our one-on-one sessions with the students. All right, so program development. When we consider the steps towards implementation, our focus primarily comes in when our office began working with the CHW training program. So during this phase, adjustments were made to the application process, especially in terms of adding questions to ensure applicants and participants in the program had lived experience with HIV. The team was able to develop and disseminate this application. Another item that has been important to our office when implementing this program is determining where students are going to get their field experience. So before we're training people, we are asking the question, do either we or our partner offices and providers have the capacity and availability to provide them with field experience? In that process, we've identified internship routes here at the county Department of Public Health, and ultimately we're really standing in the position that they need to be getting paid for their work as interns and as CHWs. So we're excited to say that our interns will come on this summer. We'll have 3 interns for 6 months in part-time paid positions, which we're very excited about. All right, I just did want to take a moment to kind of outline the student experience from start to finish so you can get an idea of what that looks like. So first, prospective applicants visit ehechamp.com and they'll complete the online application. When they submit it, I, as the CHW trainer, will review their application. If the applicant meets program eligibility criteria, I will arrange a phone call as an introduction to provide a detailed overview of the program, its structure, and what the career would look like if they want to pursue it. If the applicant decides to proceed, I enroll them right then in our learning management system, and I'll make sure that they have access to modules 1 and 2 in the very first week. Additionally, I will schedule bi-weekly one-on-one check-ins to provide support and guidance. And while attendance at these sessions is not mandatory, I do encourage students to take advantage of the opportunity for discussion and assistance in the program. Moving forward throughout the program, students go through the online modules with each one unlocked as they advance. Upon completing all modules and passing the final exam, I issue a graduation certificate and complete their study hours form. The study hours form is a required document for CHW license application in the state. As their trainer, I continue to support students beyond their program completion, assisting with license applications, job searches, resume writing, and connecting them with further learning opportunities and career resources. This comprehensive support ensures a seamless transition into the field as competent and qualified CHWs. So, how do people know that we have a training program available to them? Promotion and advertisement play a crucial role in informing individuals about CHAMP training. Since the program's relocation to our EHE office, our promotional efforts have significantly grown. We printed flyers for distribution at agencies and our providers and distributed them at local events like Pride and health fairs, where we're already staffing our Positively You booth for Ryan White outreach. Additionally, we leverage our client newsletters, Positively You newsletter for young adults, and the Ryan White community newsletter for clients overall to spread the word about the program. Social media platforms through our Positively You channels serve as another avenue for promotion. We also track statistics on how people hear about the program when they apply. And so we've learned that client newsletters are actually the most popular way for people to learn about the program, but that's closely followed by provider referrals through the distribution of those flyers. This reinforces to us that it's good practice to try to reach people through multiple strategies, because different avenues are going to reach different people, all who may want to participate or learn more. Along that line of thought, who are we reaching? So we want to take a look at the individuals we successfully reach. So reviewing our data and demographics, we've had a total of 46 applicants overall time since we moved in-house. Out of these, we were able to enroll 36 people. Some applicants, if they're not being enrolled, they might be deemed ineligible either because they indicated they did not have HIV, they lived out of state, or maybe they became unreachable after they sent in the application. So those individuals were not enrolled. Analyzing our enrolled individuals based on gender, as indicated in the application form, we find that the responses closely mirror the demographics of our local HIV epidemic. This application form did allow applicants to freely fill in the information with text, and that is what is depicted here on the graph. Similarly, if we take a look at demographics for those enrolled in the program for race and ethnicity, we find that our two largest groups represented are Hispanic and Latino and white. Then they're followed by our Black students and our Indigenous students. This is good to understand and note because this graph is also what we would expect to see if we were trying to reach people with HIV represented by ethnicity in our local epidemic, which we are. So, taking a step back and looking at the program, we want to make sure that we are meeting the needs of the students and remembering some considerations to keep in mind. The first thing to look at is time and scheduling. Our program typically requires about 80 hours to complete for the student, but this can vary greatly depending on their needs. Initially, we estimated that dedicating about 5 hours a week for about 16 weeks would suffice, but we quickly realized the importance of flexibility, especially when it is a completely online program. So we transitioned to an open enrollment system, which allowed students to sign up and complete the program at their own pace. We are considering a return back to the cohort method in our future iterations, but we found a balance by looking to offer multiple cohorts throughout the year. So this ensures students do not have to wait extended periods before they start the program. Next, we want to make sure to look at the digital divide. While many of us are comfortable working with technology, we have to remember that not all people share the same level of this proficiency, especially when we look across different age groups and income levels. A lot of time people will think, oh, young people are really technically savvy, but if you did not grow up in a home with a computer and you've only used smartphones, you might be totally unfamiliar with Microsoft programs or email etiquette or any number of a computer's applications that are necessary in our field. Our program aims to bridge this gap by connecting people with free digital skills training for applicants who need it and helping individuals navigate essential computer applications in the workplace. We also offer assistance to those lacking access to computers or Wi-Fi. In the student application, we ask if they'll need help with accessing a computer and Wi-Fi, and I'm always ready and excited to be connecting them with resources through our county libraries, which provide free Chromebooks and hotspot checkouts for 3 weeks at a time. I was excited to be on staff with the library when they rolled out this program, and I did training for checkouts for these items, and so I'm always very excited to promote this program with as many people as I can. Another consideration is accessibility of curriculum. So we want to prioritize web accessibility standards to ensure all students can engage with the content effectively. So this comes into play when thinking about font sizes, contrast, and image descriptions for screen reading technology. Additionally, it is important to remember accessibility when you have videos in your training program. You're going to want to make sure that there are captions there as well, which we make sure that we always have captions. Lastly, we focus on job readiness and career support. We assist students with resume building, interview preparation, and job search strategies, connecting them with local job opportunities throughout our network of partners and providers. By providing comprehensive support, we empower students to succeed in their careers. All right. So taking a look at some quotes is our qualitative data from the students. So you'll see on the screen there, they're expressing things like, this knowledge is invaluable in my role as a CHW. It allows me to contribute to the early detection and management of health issues. Another student said, I learned that you can be supportive and caring while being helpful and informative, which seems to be the main concept of being a CHW. This is a concept utilized every day. Lastly, another student noted, I learned a lot about cultural diversity, which I believe will be very useful knowledge for CHWs, as we will be working with many different cultures. Each of these comments is really actually exciting to hear specifically because they're each talking about different actual core competencies in the program that are outlined. We also want to take a look at inactivity. So an essential piece of qualitative data to consider is the question, why do some students become inactive? You haven't seen this yet, but on the next slide, we'll talk about graduation numbers. But while we receive a significant number of applicants and enrolled individuals, the number of students completing it is not as high. So we're taking a look at self-reporting during our biweekly check-ins. Why are students becoming inactive? So a lot of these kind of reasons are significant life events, health issues. Sometimes they'll get new jobs in between applying. So they want to start this career, but they get a different job in the meantime, or simply having busy schedules. And then a couple of students also moved out of state. Despite being inactive, many students remain responsive. which indicates a potential desire to re-engage with the program, as far as I can see. So when their circumstances permit, we're happy to bring them back in. So program successes. We're celebrating 6 graduates, all of whom have completed the additional 480 hours of fieldwork. These graduates were either connected to CHW roles or were in CHW roles and were seeking further professional development. Additionally, relocating the program in office has led to increased promotion and visibility. We're of course seeing applicants come through our provider referrals, which is really rewarding, and providers are even reaching out to inquire about promoting it further, requesting more flyers, which is really exciting. And then of course, as I mentioned, our other exciting development is the launch of our internship program this summer. And finally, we're excited because we're currently assisting our graduates with application for voluntary licenses in the state. So the application fee in Arizona is $300 to get certified as or licensed as a CHW. So we help research scholarship opportunities, but we are prepared as payer of last resort to pay that fee for the students so that they can become licensed in the state. All right, present and future. In summary, our current work involves collaborating with our sibling offices here at Public Health to expand our CHW training program. Our goal is to offer a comprehensive training pathway supplemented by specialized modules, like ours is HIV modules, but another office may have different modules. And our office is specific to our EHE students. We're currently undergoing big revisions to the program. We're redesigning the curriculum and Articulate. We're facilitating the easy translation into Spanish, and we're making the program more streamlined and more accessible for the students. Additionally, like we said, we're reintroducing cohort-based learning to build community. We're enhancing training for the instructors themselves, which aims to ensure the long-term sustainability of the program. And of course, our immediate plans are getting reaccredited this summer and translating the program into Spanish and launching our internship initiative in the coming weeks. And that is what I have for you. And that is my email, and you can view our website at ehechamp.com.
Thank you so much, Jen. And thank you to our colleagues from South Carolina as well. We have a couple of questions in the chat. I think this first question is for South Carolina. How long was the community health worker program in place before the specific recruitment started? And how were those existing workers initially recruited?
I'm going to turn to Susan to speak to the overall public health, community health worker initiative that grew quite widely during the COVID years. Our EHE specific community health worker program was really just getting rolling with the Midlands region that Susan has a key role in 2022. So we had really rolled it out just in terms of the pre-planning stages for a few months, and then Midlands really jumped on it very quickly as the pilot. So Susan, do you want to speak to how where you recruited your key folks into the program? You had several years at least of community health worker activities.
Yes, sure will. Yeah, we fortunately had one of our staff in leadership in the Midlands was always very interested in community health workers. And COVID gave us that opportunity to begin hiring community health workers on staff. So our first community health workers were in fact COVID hires. They were rapid hires, and many of them were hourly. And we really looked for folks who have lived experience in those communities, who were well known in those communities. We needed folks who were trusted right from the get-go and had some experience in doing some kind of community work, whether it was through their churches or other kind of volunteerism or other connections. And the program grew very rapidly. We were very, very fortunate. And we have many of the staff that started with us are still with us. And we have been able to move staff off of hourly onto temporary grants as opportunities arose. And we have continued to grow the program and are really looking to having it be this blended funding, split funding, whatever you want to call it, where these folks can really address that whole person in the community. And Tony referenced, I just wanted to throw in that he was hoping to expand this beyond in the Midlands, and he knows this, is already working to have more of our CHWs, even though they may not be funded directly, but to have them go through some of the same training so that they can better provide the services to those communities as they reach out.
Great, thank you. And there was another question. This question was specifically for South Carolina, but I would be curious to hear from Jen about Maricopa County. What is the starting hourly rate for CHWs?
So our community health worker, the budget we have for them, we're actually funded them as full-time temp grant employees, so not hourly, at a starting of $40,000. That has already gone up from what we set in 2022 to basically with some cost of living increases that our state legislature offered us nicely, of course, having to find it in the federal grant money to make that work. But it is in the low 40s for the starting. In the Midlands, I'll just mention that Susan creatively went to some of that existing workforce she had and said she had 3 folks, each with unique reaches to the community, whether it be bilingual and from the Latinx community or LGBTQ or other particular populations they could reach. So she made her case for taking the same pot of money and stretching it a third, or whatever the variation was to still use the same. So we got a real big bang for the buck there.
I saw Jeremy hop on. I know you're ready to answer.
Hi, everyone. I'm Jeremy Hubbard. I'm the subdivision manager here at Maricopa County for the Ryan White and Part A and EHE programs. So we have to, because it's an internship program and we're following the with public health, so we fall in line with what they are. So we what their hourly rates are. So we're doing $20 an hour for the 20 hours a week until they reach their 480 hours to do that. So yeah, it's not the highest paying internship, but with internships, there's a lot of, particularly with the there's some regulations about how much we can pay for internships. So because we're filing underneath the internship program at the county and using that that structure, we needed to stay within what they're doing so it's competitive with the rest of the internship programs. Did I say that wrong, Jen? I think I was corrected. It's actually $22 an hour, not $20 an hour. My apologies.
I'm curious, and this question is for both health departments. But have you all, so for South Carolina, since you all are already in the field, kind of doing the work, what kind of feedback have you heard from community about the community health worker program? And then for Maricopa County, I'm curious what feedback you've gotten from the folks who have gone through the certificate program.
I think, Tony, if it's okay, I'll just jump in from my perspective in the Midlands, is that we've gotten really positive feedback from the community, particularly with community partners who have community health workers on staff. Because their community health workers work a little bit differently than ours do. And so they really so what we're working to do is we're establishing relationships, community health worker to community health worker in these communities. And I think one of the things that when you talk about the reception of the community health workers in the community, I think that is tells us a lot is that many of these folks are folks who would probably not historically step foot into our health departments, being a government agency, et cetera. And we are able to get them connected to our services. And I think that speaks volumes for the impact that the community health worker can have in our communities.
And on our end, feedback has been positive as well. I know a lot of students really value, like, a few of the core competencies are like very relevant to like everyday life, but it also prepares them to enter the field. Specifically, people were excited about motivational interviewing, getting to do like an entire module basically covering that has made them feel like more prepared to enter the field. But they've also said in their personal life, it has kind of changed how they're able to relate to other people. And going over communication, like and like you said, Susan, kind of people who may not have typically like had access to this type of training, it's really exciting for them to kind of go through and like get more hands-on knowledge about different things in the field that are going to help out. And they've kind of said that as well at the in the course evaluations at the end of the course as well.
Great, thank you all so much. I'm not seeing any other questions. So we can go ahead and wrap up. I just have one additional slide. Thank you all so much for joining today, and thank you to all of our presenters. Also want to just say thank you to our partners at CDC. Please do reach out to NASTAD. You can reach out to us directly or through the CTS system if you would like to request technical assistance. And as I said before, we will share the slides and the recording from today with all registered participants, as well as on NASTAD's website. Thank you all so much. We hope to see you next week, Tuesday, at our next webinar. Have a great rest of your day, and we'll see you next time.
Thank you.
Thanks.